Okay, Grandpa, we're here.
Dr. Doing that with videotaping. They're going to videotape.
It's fine. Can you hear us?
Yeah.
Okay. Hi, I'm Dr. Yoon, and I'm going to be the one holding the heading up the conference today. Okay, and so if you have any questions, please stop me and ask, okay?
Okay.
All right, so I'm just going to get everyone on the same page here because I've been talking mostly to Mom and Dad, but I just want to make sure everybody hears what I'm saying. But so Marco has been diagnosed with a type of cancer that is called rhabdomyosarcoma. It's a very long word.
Can someone write that down and text it to me later?
You know what? I'm Joanne. I'm one of the nurses, and I'm taking some notes. And if we get some email authorization, then I can email you my notes when we're all done.
Oh, okay. Oh,
Okay.
yeah, that's even better.
All right. So rhabdomyosarcoma is a childhood cancer that we treat, and unfortunately, Marco's is such that it has spread to some of his bones, specifically some bones in his vertebrae, in his spine, and also to one of his ribs. And he also has spread to his bone marrow on both sides, which is the factory for white blood cells to help fight infection, red blood cells that carry oxygen through the body, and platelets that help you to clot when you start bleeding. So by definition, because of the spread of this tumor to multiple areas, specifically the bone marrow, he has the highest stage group, which the lower the stage number, the better prognosis. The higher the stage number, the lower the worse the prognosis. And unfortunately, the location of his tumor is also problematic for us in that it is deep down in his pelvis, sitting right before his tailbone. And if you want to take a look at the pictures, we can pull up the MRI and show you what it looks like. Sometimes it's helpful to see a picture. Would you like to see it? Can you pull that up for me, please? And so we'll show you what that looks like. And unfortunately, this is one of those tumors that in order to achieve the very best control of it and to get the best outcome would require surgical resection, meaning being able to completely remove it. And unfortunately, Marco's tumor is such that it is so extensive and is in a location that is not feasible to being removed completely by surgery. And so we have our work cut out for us in terms of treating him.
Dr. Yoon, you stated that due to its nature, you cannot remove it completely via surgery. Are there other options, other ways to remove it then?
There are not ways to remove it. There are ways to shrink it. That would be with chemotherapy and radiation therapy.
To what extent has it gone to the marrow? Has it
He
just
has-
the early stages of it, or has it fully gone through everything?
It is pretty extensive. I believe on the right side, he has 100% involvement of his bone marrow with tumor, and on the left side, he has 80%. That's very extensive.
Wow, yeah. Okay.
Okay.
This
Chat team to PICU. Chat team to PICU.
This type of cancer, what's its runtime? I mean, how long could we say has he had it? Has it been something that's just been going for a while? He's had it for a long time?
It's not on the. He hasn't had it for years. He's probably had it on the duration of a couple months.
A few months.
Tumors are very fast growing. We'll never know how long it's been there. Unfortunately for him, because his tumor started in his sacrum, which is an area that tumors can hide in for a very long period of time, they don't come to light until they start putting pressure on structures around them. So his didn't become apparent, or there wasn't concern for anything going on there until he stopped having difficulty having bowel movements, having pain. They don't come to light until they start showing
So it's
symptoms.
not something that's been laying dormant all his life?
No.
And then just, okay.
No. He was
A
not
lot
born
of
with this.
Parents have guilt and think back and wonder if they missed something, and we just want to lift that burden off of you. It presents when it presents.
Well, I have a question. We 2 weeks prior to coming here, we had went to Palomar Health and we had gone there 3 times, and then the third time we ended up coming here. The first time we went, they did take X-rays of his pelvic area. Do you think they could have seen it in their X-rays?
No.
Not at all.
X-rays are not good enough definition to see something like this. To see something like this, you need MRI or CT scan.
Okay, yeah, because they did say that he was constipated, and that's what they diagnosed us with his X-ray.
You would not be able to see this on X-ray.
Okay.
So I'm just going to pause here for a second. I'm just going to show you what we're looking at. So, sorry, these rooms get very, very tight. So this is his scan, and this is kind of slicing him this way. So his head is here, his feet are here, and we're slicing down like this. This is his front, this is his back. Okay. This is a nice view. Anything with black is air. So these are his lungs up here, and here this is his bowels, and they're supposed to be black like this. Here you see this. Actually, there's another view I like better. Hold on 1 second. We're now slicing him this way, going through his body. This is his front side, and this is his back side here. We're going down. This is his liver, spleen, moving down. And okay, so this is his bladder that is very full and is being pushed forward. Your bladder we shouldn't be able to feel your bladder when we push on your belly. His, you can completely feel the dome of it because there's a tumor right underneath the bladder that's pushing up on his bladder. So all of this here, it's not very even in texture, in structure. It just looks like a big blob, a big mass. All of this should not be here. This is all tumor that we're seeing here.
I see.
When you go back to this image, which is slicing him up and down this way, this is his spine that you see here. And his spine should be his spine should be pretty even in its appearance from the top down to the bottom. And as you can see, his spine looks irregular in places. And that's because there is some tumor involvement in some of the vertebrae in his spine as well.
The darker areas there, is that
In here?
is that signs indication of where the cancer have gotten to, or
No,
is
this is bone marrow.
That's bone marrow,
in
okay,
the
the dark
vertebrae,
area,
But
okay.
when it's nice and when it's really bright like this, the vertebrae shouldn't be this bright.
should not be that
And when
bright?
it's this bright, it says that there's tumor in there.
I see.
Okay. So that's what the scan looks like. And so this mass is problematic in many respects, and I'm going to go through each issue that we're having and what we're going to do to address it. Because of the location of the mass, it is kind of encircling itself around the nerves, and specifically the nerves that come out of the sacrum, which is near your tailbone. And the nerves that come out of that area control your stooling, your bowel movements, and your urination. He does not have control over either of those functions anymore because of this mass. So for the urine, the Foley catheter that we place is just a temporary measure. That really is not meant to stay in long term. It's also an infection risk, and he already has a urinary tract infection, most likely from that Foley catheter. That's why we sent him to the operating room today to put in what's called a vesicostomy, which I explained to you is just kind of a little hole that sits like in his pelvic area, and his urine is going to drain out of there. It's important to maintain very good urine flow because of the chemotherapy that can potentially damage his bladder, and we don't want that to happen. So that's issue number one for the vesicostomy. In terms of the stooling, the ultimate measure to kind of help him stool would be what we call kind of a diverting colostomy, which is where we would actually have the surgeons go in, resect, take out part of his bowel, and instead of the bowel emptying out through the anus, we would bring the bowel up to his skin, and we would put a pouch on him, and he would stool that way. That also has huge risks associated with it, and I really don't want him going to the operating room right now for that. That's a much more invasive procedure than the vesicostomy. So what I want to do right now is start chemotherapy and radiation and shrink this mass down and see what kind of functioning he'll maintain or regain with that. This tumor, these rhabdomyosarcomas, there's two subsets. There's a type that's called embryonal and there's a type that's called alveolar. And we're sending off some specific genetic tests. And genetics not meaning that you pass this on to him, but different tumors have certain genetic markers that tell us what type they are. And we're waiting for those tests to come back, and that can take about a week or 2 weeks to come back. So it's not fast information. But the way his looks under the microscope, it looks like it's a subtype called alveolar rhabdomyosarcoma, which has a worse prognosis than embryonal. They're much more aggressive and they're much harder to treat. So his is going to be a big challenge to us to ultimately treat it because of its location, number one, the body functions it's already affecting, number two, and the subtype of it. I think if it really does come back to be alveolar, which is what it looks like, those tend not to respond as well to the therapy that we have to give him. But with that said, we are going to give him the very best therapy we have while being mindful of the toxicities associated with the chemotherapy. So we have what we call a tumor board, and that's where we sit down and talk about patients that are complicated like Marco. And we talk about the different treatment options and what we should do in approaching a patient like him. And so I presented him today at our tumor board, and the consensus that we came up with is to treat him. There are different risk kind of grouping for rhabdomyosarcoma, and by definition, he's in the highest risk group. There is a treatment plan for patients in the highest risk group, but this very toxic chemotherapy, and it could be associated with lots of risks. And I think because of all of the other issues that are going on with Marco right now, it makes the most sense to step back on his chemotherapy just a little bit, not meaning that I'm not going to give him aggressive chemotherapy, but I'm not going to give him the most aggressive regimen we have. I'm going to be giving him a regimen, and I brought the drugs, handouts of the drugs with me, which I'll go through with you today. But I'm going to be using a 3-drug regimen. The drugs are vincristine, actinomycin, and cyclophosphamide. They're very good drugs that work in rhabdomyosarcoma. These drugs will be given every 3 weeks, every 21 days to him. And we'll also be giving him, in addition, I want to start radiation therapy for him. Radiation will also shrink this tumor down, and what you're going to see, and what I hope to see, is symptom control pretty quickly, meaning he may regain some of his ability to stool on his own. I'm hoping regain some ability to maybe urinate on his own, and the biggest thing for me is minimizing the pain. So he's having a lot of pain, mostly in the backs of his legs, because this mass is encompassing the sciatic nerve, which is a very big nerve that runs down the back of your leg and can be very painful when it's compressed. And this mass is completely compressing those nerves. And so we need to get the pressure off of the nerves, and it's not safe to go in and surgically take this mass out. It would be a very gruesome, difficult surgery to do, and it wouldn't give us a much better outcome than where we are right now. So the plan is to get the vesicostomy in today and start chemotherapy tomorrow. The radiation is not done here at Rady Children's. It is actually done at UCSD, and if that's what we choose to do, we would transport him back and forth to UCSD. And that is for the traditional radiation modality, which is called photon treatment. We have a brand new center that we just opened with Scripps, which is called proton therapy. And proton therapy can be a little bit more gentle. It's still as effective, but it's a different way of
administering. Does it focus in on just one, that's a more acute area than the... No, it does not. It still just eradicates everything.
And his field is going to have to be very, very wide because this mass is very, very wide.
Will you be running this therapy, this radiation, in the same time as
Yes.
administering the drugs?
Correct. There are some, when he starts radiation, I cannot continue some of the drugs. Actinomycin, I cannot give him along with chemotherapy because actinomycin can exacerbate the radiation side effects. And so I will not be giving that to him once he starts radiation. It's safe to give it prior to, but I won't give it during.
So the stages that you're giving, you said every 21 days they'll be receiving the drugs. Now, we say we're going to begin that tomorrow, you stated. Now, as for the radiation therapy, that would begin when then?
So
You have
I'm
to wait for it
hoping,
to wean off of that?
No.
That 21 days? Or?
no, I'm hoping to be able to start it sometime next week. So I have already communicated to our pediatric radiation oncologist, Dr. Kevin Murphy, and we already discussed Marco's case. And so what needs to be done is we need to get him over to Dr. Murphy and his team. And they would first start with what's called a simulation, which means that they have to plan out how those radiation beams are going to be targeted towards Marco's tumor. And whether it's going to be photon therapy or proton therapy, the centers will be different, but it will be Dr. Murphy who'll be overseeing it. I think Marco has extreme anxiety, as we already know, and he has every reason to be very anxious. So we're going to try to minimize the trauma of anything we do to him. And for radiation to be its most effective, he's going to need to lay perfectly still so that the radiation beams line up perfectly to target the tumor, which means for him that he's going to need sedation every time.
Yes.
Every time.
Yeah. Okay. Do you have any questions based on anything I've said so far?
It's a lot.
It's a lot.
Radiation therapy will be done at UCSD?
If it's photon,
If it's photon?
if it's proton, it'll be at Skirps.
Proton will be at Scripps?
But we would transport you to both places.
Now, is that a single day procedure and then come back here, or is that we're staying, okay, we're going to prep you the day prior, you're going to stay there, then the following day you'll have it, and then,
So what happens first is that you'll go there and he'll be intubated and sedated for what we call the simulation. So the simulation is where Dr. Murphy and his team will do another scan and then they will plan out their radiation mapping. That can take days to a week to put that plan together because it's very complicated to do so. When the plan is ready, he'll contact me and tell me I'm ready to start, and then we'll start transporting him. The radiation itself is very, very quick. Matter of 10 minutes and you're done. The longer part is going to be getting him there, putting him to sleep, doing the treatment, waking him up, bringing him back.
and then bringing him back to monitoring will be done.
I do not anticipate him leaving us anytime soon. We have so many issues that need to be worked on. We have so much that we need to teach you. And the criteria for me to be able to send him home, his pain has to be controlled on oral pain medications. He needs to be able to eat somehow. Right now we're going to feed him through his IV. You need to know how to take care of his central line. You need to know how to take care of his vesicostomy. We need to monitor him for skin breakdown because as his stool continues to trickle out and it lays in the skin, it can cause breakdown. So I'm just going to tell you now, just get very comfortable with us because you're going to be here with us for a while because this is not something that's going to reverse very quickly. But I anticipate after starting the first doses of chemotherapy, he should be starting to feel better. Hopefully within a week or so, he should start feeling better. And you will probably see noticeable changes in how he's acting.
Okay.
So the chemotherapy itself is pretty quick. The 2 doses, the vincristine and the actinomycin, are pushed very quickly through his central line. Everything will go through the central line. And then the Cytoxan or the cyclophosphamide is given over a longer period of time, over an hour. That's the one that's very important to get out of the bladder because it can cause toxicity to the bladder. So we're going to give him lots of fluid before and lots of fluid after and just make sure he has good urine output and pees it all out. It can cause some damage to the bladder wall, and so we'll be checking his urine to see if there's blood in the urine. That's going to be important to monitor. Because this chemotherapy, in addition to targeting the tumor cells, is also going to target normal cells, what you're going to see is his hair is going to fall out, and you won't see it right away. It usually takes about 2 or 3 weeks for it to come out, but when it comes out, it doesn't just come out little bits at a time. It's clumps of hair at a time. So some parents just choose to go ahead and he's a boy, buzz his hair now so it's not as traumatic to him. That's something that you guys can think about doing now.
That's what we were thinking about because
Yeah.
I don't want, he will freak out.
Yeah, so it may be less traumatic if you just go ahead and do it now. In addition, other rapidly dividing cells are cells in our mouth. They're rapidly dividing, so he may be developing mild sores. We have good medicines to combat that, but that would be a side effect that we'll be monitoring him for. Other cells that are rapidly dividing are bone marrow cells. They're constantly being produced, and our bone marrow is constantly producing the white blood cells, as I told you, the red blood cells and platelets. Because the chemotherapy is not only going to target the cancer cells, but also the normal cells, I can guarantee you at some point in time he's going to need blood transfusions. He's going to need blood and or platelet transfusions. I can pretty much guarantee you that he's going to need both. So parents do ask sometimes, families do like to know if they can donate on his behalf. We do have a program through the San Diego Blood Bank. It's called the Directed Donor Blood Program, where you can donate blood if your blood type matches for Marco. And if we don't use it for him, we'll release it and use it for another patient. Even if your blood types do not match, we have plenty of other patients who could use the blood. There is a fee associated with doing this, and you would just have to contact San Diego Blood Bank. But if that's something that you think you would like to do, it does require some paperwork from me, and I'm happy to get that ball rolling if that's
Do
something
we know
you'd
what
like.
blood type he is?
We sent it off. Let's type in screen. We'll see if we can find it.
And just know too that the blood supply is very, very, very safe. So even if you chose not
Also,
to,
we are at safe
I've
levels
had-
right now. Then it's not we don't have a shortage of anything. Okay.
and safe that they screen it for
Yeah.
any kind of infection.
Oh.
or
I've had a transfusion. I know.
Have
I
you?
just did it with my pregnancy.
Oh, okay,
So,
been through.
and I'm A negative, so that's why I'm wondering what his blood type
We
is.
sent it off. I don't remember seeing it, but I believe we sent it. If we didn't, we'll send it.
Yeah, we did.
Yeah, I remember sending it early on. So for white blood cells, we don't transfuse white blood cells. And the way we get the white blood cells, what is it?
A positive.
A positive. So the way we get the white blood cells, the bone marrow to start generating white blood cells, is there is a medicine, and it's called, we can do one of two, and I think I already know which one I want for Marco based on getting to know him. There's one that's called GCSF. It's given subcutaneously. It's given 24 to 36 hours after chemotherapy, and you give it daily for about 10 days to really boost his white cells up. That is a shot. I'm sure he's going to hate it. So there's another alternative, which is called Neulasta, which is a one-time subcutaneous shot given in the same time period after the chemotherapy, but it lasts for 2 weeks. So that's the one I'm going to order up for him.
Yeah, because needles right now with him, it's not going to happen.
So the problem is, yeah. So sometimes Neulasta is limited by insurance and all of that, and we can't. There's some restrictions on how it can be given in the hospital. If we can't get Neulasta, if he's still in the hospital, well, he is going to be in the hospital. If we have problems getting the Neulasta to you to give it to him, we can do the GCSF, the other white blood cell stimulant. We can give it to him IV, so he won't have to get the shots. But eventually we're going to, if we get him to a point where he's going to get home, it is something that we're going to have to teach you how to give him, because you will have to give it to him
Shots, yeah.
home. Okay?
And it's a little teeny tiny.
It's like an insulin
Shot.
syringe. It's
Oh, yeah,
it just
I've
goes
done
under
it
the
before.
skin.
The little insulin from
Yeah,
my grandmother for
yeah,
diabetes.
It's the
like
same.
that.
Okay. And now we're speaking of home. I just want to make sure that you are going to continue your care here, that the idea of Loma Linda is not on the
No,
table.
no.
Okay.
Yeah.
All right. I just want to make sure before we put all of this stuff in motion. I just want to make sure. And that also brings me to my next point. If at any point in time you say, I want a second opinion, I want to be able to talk to other people in the country, I want to go elsewhere, you are completely within your right to do so. I encourage you to do so. If you ever have that lingering doubt in your mind that you feel like you need to go elsewhere and get another opinion, I just ask that you come to me and tell me, because I will pick the centers for you to go to. There are centers who are known for treating rhabdomyosarcoma, and I will direct you to the appropriate centers. And just to let you know, this treatment plan that I've come up with for Marco is not just from me or from Brady Children's. We operate within a larger network of children's hospitals, as I explained to you previously when we thought this was neuroblastoma, the Children's Oncology Group. And so the treatment that we're going to give to Marco has come from previous clinical trials of patients just like him. And in addition, because his case is so complicated, I've already reached out to one rhabdomyosarcoma expert in the country and asked his opinion of what he would do, and a lot of the treatment that I'm presenting to you is coming from him. In addition, because there are a lot of complexities to his case, I'm going to also be emailing some other rhabdomyosarcoma experts and just kind of getting their feel. Nobody's going to be able to say, this is the way to do it, this is the only way to do it, this is not how it works. What we do is we take into consideration everything that's going on with Marco and come up with the plan that's going to best suit him. But I'm just going to tell you now, this is a plan that I'm choosing to start with. I may alter the plan as we go along based on how he responds, and I will always keep you in the loop. If I'm changing things, there's a good reason for doing it, and I will tell you why I'm doing it. I think those who have worked with me will tell you I will be completely upfront with you. If I'm worried about something, you're going to be the first to know. If I'm happy about something, you're going to be the first to know. Nothing is to be gained by me hiding things from you. And so today's conference is to let you know this is an aggressive tumor. This is going to be a challenge to treat. I'm going to give him everything that I've got, keeping in mind the potential toxicities of the treatment that I'm going to give him to give him the best possible outcome. But this is going to be an uphill battle. Okay. So,
Do you guys, are you good with straightforward information? You want us to-
Yes.
Yes?
I
Okay.
gathered that
Yes.
from you guys, so.
Because we can try to, go little by little if it's too.
And you tell me to stop whenever, and you're going to have a gazillion questions based upon what I've said today.
Yeah,
You
after
just
we-
keep writing them down, and you keep asking me, because this relationship works with us being open and communicating with each other. So you ask. I will be your primary oncologist. I will be the one ultimately making all the treatment decisions. You may not see me every time you're in the hospital. You may see my partners, but any plan that is directed at Marco is going to come through me. So if there are treatment changes, they're going to come from me. If there are updates that I need to give you, important updates, they're going to come through me. Okay. So, as we previously talked about, this is not neuroblastoma. So we have the counterpart to neuroblastoma for rhabdomyosarcoma, which is the biology study. Same thing. It gets sent off to the experts in the country. Any tumor that we didn't use for diagnosis will get banked away so we can study it for future patients. Are you in agreement to doing that?
Yeah.
So, this is for you, for your records, just telling you what this is about. That we're not going to do any additional testing on him for this. This is giving us consent to use his leftover bone marrow and leftover tissue to be sent off to the experts in the country who are just trying to figure out how we can better treat this tumor, okay?
So since there's no more tests being run, that means we know 100% sure it is rhabdo.
Yeah. Rhabdomyosarcoma is muscle origin. It has very specific markers. It stains for muscle markers. All of his muscle markers are strongly positive.
Okay.
There is no question what this
So we don't need
diagnosis.
to wait the 2 weeks for it to get the
The
marker right
alveolar,
then. I mean,
it doesn't change what we're going to do. I'm going to treat it the same way. Ultimately down the line, it may make a difference it's not going to make much of a difference because the treatment is the same. It's just
so
a
therefore we
prognostic.
don't need to wait
No.
for anything. Okay.
And to be quite honest, his tumor is advanced enough that I need to start treatment.
Good.
I need to get him.
We just want to make sure there's no hold up on it. Let's get to it.
I didn't want to start the chemo until I had a good urine source in place,
Yes.
and the vesicostomy was
So the Foley's
crucial.
out now. We got the vesicostomy in there.
We can start.
Okay.
We will start tomorrow. I don't like to run first chemotherapy at night. It's just better to do it during the day.
But the
when
Foley's
everybody's
out now, and we have the okay.
So that I'll take from you. And then this, once again, gives me your authorization to look in his medical record to send off the information. His identity will be kept completely confidential. He'll be assigned a number, and that is how he's going to be referred to for this study, okay?
So everything will just be attached to his MRN then?
I'm sorry?
Everything will just be attached to his MRN then?
It's not going to be attached to his MRN. Actually, he gets a COG ID number, Children's Oncology Group ID number, and that's what he'll be referred to as from now on. Thank you. And then, this is for you. And I can make copies of these if you want to, so that you can all have them. So here's the chemotherapy, and I'm just going to kind of, oh, I forgot to print up the pictures. No, I forgot to print up the Vincristine. Oh, Vincristine. Can you get Vincristine for me, please? I'm sorry. And
We're gonna need copies.
yeah, we'll get you copies. I meant to print everything and I was multitasking and I forgot one of the drugs. And we can give you like a binder for all of this, and I can also give you, parents sometimes like to see the actual roadmap to kind of see how the drugs are
that's what I
given,
was gonna ask.
and I'll give those to you too. I just didn't want to overload you today, so I'll give those to you as well. So cyclophosphamide. Cyclophosphamide is the drug that can cause damage to the bladder, so it's really important that we hydrate him. This drug is associated with nausea and vomiting. We're going to have lots of drugs available to him for nausea and vomiting. The Zofran will be scheduled. In addition, he'll have medications as needed. If you feel like he's still having nausea and you need more, there's going to be drugs available on standby. So you just ask for it, okay? So that's cyclophosphamide. All patients will have nausea and vomiting with cyclophosphamide. It's just a given. The hair loss. Because of its effects on the bone marrow, his blood counts are going to go low. They're probably going to go low about 1 to 2 weeks after the chemotherapy. If and when we get to the point of when you can go home, parents always ask me, do I need to keep him in a bubble? You know, how safe do I need to keep him? We want him to be as normal a 5-year-old as he can be with this diagnosis. So just get in the habit now of good hand washing when you go in his room and out. Just gel in, gel out. Anybody who's got even the slightest bit of a sniffle, that could be nothing for them, but a big deal for him. So anybody who's sick just needs to not be near him right now. And then we're going to give you lots and lots of education on things to do when his blood counts are low. And you're actually going to get in a rhythm with us, because we'll tell you his counts are low, you need to avoid crowds, you know. We'll educate you on all the things you're going to need to know, okay? The other one is called actinomycin. Actinomycin will also be given through his central line. Nausea, vomiting, hair loss, mouth sores, low blood counts. Rarely patients can develop allergic reaction to it. I haven't seen it very often. I think he'll be just fine. Okay, but this is one of the side effects of actinomycin. This is a drug that is going to need to be held when the radiation starts, because if we give this with radiation, it could cause some serious skin effects. It can cause some serious side effects. This is the colony stimulating factor, the GCSF, or the Neulasta. My plan is to give him Neulasta, which is the one-time shot that will last 2 weeks, but it kind of gives you an idea of what it's for. It's to stimulate the bone marrow to make the white blood cells. You can have some bone pain with this because we're revving up the bone marrow to produce good white cells. And sometimes patients complain of kind of flu-like symptoms, some fatigue, just not feeling great, but it's a really important drug in our arsenal because it helps us stay on target with his chemotherapy every 21 days. In order to proceed with subsequent cycles of chemotherapy, there are certain blood count parameters he needs to meet, and if he has having any kind of infection or things like that, that would be indication for us to hold. But we try to stay on target as much as we can, knowing that there are going to be delays. And then this is the last one. This is called Bactrim or Septra. Patients who are on chemotherapy are prone to developing a certain type of pneumonia. So this is a drug we're just going to give him on the weekends, twice a day on the weekends only, and just by doing that can help prevent this type of pneumonia from happening. So that's another drug that he is going to be on. So this is, and then the Vincristine, which we'll get you the handout for. The Vincristine typically doesn't drop your counts. It's also going to be given through the central line. That one is associated with constipation. It can be also associated with, it affects the nerve endings, specifically in your hands and feet. So he may complain of some numbness and tingling, which is really common. Some patients, it gets to the point where they have such bad pain that we may have to cut back on the dose, but we use it very frequently and it's generally well tolerated. There are some indications to cut back on the dose, mostly for pain associated with the nerve ending. Okay. And then in terms of his central line, so the particular line I chose for him was based on the fact of the presumption that this was neuroblastoma. By imaging, it had all the right characteristics and it looked very classic. And so we put in that particular line because, as I told you, we were going to collect his stem cells from the line. That's not the case. We don't do that for rhabdomyosarcoma. So he has this line in place right now. It's a good line. It works well. However, at some point in time, if it becomes problematic for him, right now I don't think a port is a good idea for him that would require needle access through the skin with his anxiety. I just think it would not be a good idea. But
We could consider down the line maybe switching him once he gets used to us and gets a little more settled in. We could consider switching him to a port later in time. And the beauty of that is that it's not going to require any care for you at home, whereas the current line he has does require
And it
daily
won't
flushing.
show as much. and
It
you
won't show it
Yeah, and you
underneath.
won't feel.
Yeah. I think right now we got a good line. Let's leave it. But down the line, and it's all going to depend on his anxiety. If it's going to be a matter, if it's going to be trauma to him, to hold him down, to get him access to use the port, it's not worth it. But that's just something else to keep in mind for later. And then the last thing here, thank
Here's the
you.
Vic
This is the Vic Christine that we talked about.
Here's the other set for, I didn't do that.
Oh, there you go. So anytime we run chemotherapy on any patient here in the hospital, our hospital requires that we obtain consent because chemotherapy is very, they are very, can be complicated drugs. And so basically by signing this consent, it is saying that I explained all the drugs I'm giving and all the potential complications. Okay? Do you want to sign? Signature, just date and time there. Any questions that I can answer right now? It's a lot. And I'm completely mindful of that. It's 5 o'clock. I know, it's okay. Can we make, see on my desk is an actual, the roadmap. Can you make a copy for Mom and Dad, please? So I can see it. So, there are some labs that we need to draw before we start chemotherapy tomorrow. We're basically been checking those labs anyway. So we'll start that, we'll draw his labs in the morning, and then his chemotherapy has already been signed off, so we can tell the nurses in the morning they can just go ahead and release it, and it's just a matter of pharmacy making the chemotherapy for me.
Is chemo going to be done in his room, or is
Yeah.
he going to be transported to? Okay, so chemo will be done in his room.
And
And
then-
when he has chemo done, he's not allowed to be. Well, right now, obviously, he can't be transported. But when he starts chemo, will he be allowed still to go to the lobby and visit with his family members like he's been doing?
So technically, he has fever, and so we try to
Yeah, right
confine
now,
them to the room when they have fever. When he's fever-free, then yeah. But
That's
we're,
what I'm saying.
Yeah,
Mhm.
we'll let you know.
While the chemo's running, though, we keep you up on the floor with us.
But and we'll teach you the procedures that are involved. We're in lockdown right now because of the viral season, so we'll let you know when it's safe for him to go out of his room. The other things are he's up to date on his shots now, but we don't give any shots while they're getting chemotherapy except for the influenza vaccine yearly. Just because their immune system is so suppressed by the chemotherapy, they're not going to mount the appropriate response to the immunizations, so they're wasted. So no immunizations. And then there are other things that we do differently now. Like a fever is no longer just a fever, so we're going to teach you who to call and when. And there's always somebody available 24/7 for our service. We're just a phone call away.
Okay. But right now, his time of going home, there's no one in the picture, so it's not even worth even looking
When
into
we're
that
close,
stuff.
I will let you know. But
Okay.
right now, we have so many things that we need to sort out. We have so many things that we need to make better. And I'm not sending him until I know that, first of all, you're going to be able to take care of him, because it's going to be a lot. There are going to be medications. There's going to be different types of care, the line care, the vesicostomy care. We got to make sure that you're up to date on all of that. And the biggest thing is right now he's still requiring quite a bit of IV pain medications to keep him comfortable. And only with starting chemotherapy and radiation will that get better.
So at the beginning of this conversation, you stated that his level of cancer is the highest, most severe possible. But because you've drawn up this plan for treatment, that means it's curable, it's fixable. We can, or is this, or else it'd be just futile to proceed. I mean, we kind of all don't mind here.
If the prognosis was so grim that there was zero chance for survival, I'd be having a very different conversation with you, and I would not be subjecting him to this chemotherapy if I didn't think that I have a chance to make things better. My ultimate goal always is cure, but I'm going to be completely honest with you, it's going to be difficult, but it's not zero. And the most important thing right now for me is to make things better, and I have a very good shot at making things much better. So right now, I know that as parents, you're already 10,000 steps ahead of me and looking at the overall survival. I'm not looking at that right now. I'm looking at this as a day-to-day, these are my current challenges, these are the things that I'm going to work on to make better, and I don't know how he's going to respond to this until we start treatment. And so this is a tumor that does respond to chemotherapy. What I'm hoping is with the first couple of doses of chemotherapy and with starting radiation, I'm going to shrink this down enough that we're going to start seeing him feeling better.
Good.
And that's what we're going to focus on, okay? And we're going to take this one step at a time.
If you do get it shrunk down enough, do you think there's a possibility of going in and taking it out, or not even at all?
You know, I think it's going to be really challenging to do so. The problem is, we could go in and we can remove the primary mass, maybe. But the problem is it's already spread to the bone and the bone marrow. You cannot cut those things out. So because of that, it doesn't make sense to subject him to this very aggressive surgery to take that out.
Yeah.
I would take it out, or I would turn to the surgeons and say, I need you to go in and take it out if it's causing lots of symptoms that I can't target with chemotherapy and radiation. But I think that between the combination of the two, we're going to start seeing some improvement in his symptoms. And so I don't think it's worth going in and aggressively taking that out, because you're still going to be left with the disease in the spine. You're still going to be just left with the disease in the rib. You're still going to be left with the disease in the bone marrow. So it doesn't make sense at this point in time. Could it be a possibility in the future? Maybe, but we'll address that when we get to it. And then parents always ask, how are we going to monitor how he's responding? And that's with repeat scans. So he'll continue to get repeat MRIs on a regular basis, roughly about every 3 months, because I need to give enough time to see some changes with the chemotherapy. If I gave him chemo tomorrow and scanned him again on Friday, I'm not going to see noticeable change. So I need to give enough time to see some changes. So scanning every 3 months with MRI, and then with repeat bone scan, and then also repeating his bone marrows, and we'll do that when he's asleep. The other test I would like to get, there's a scan that's called a PET scan, and a PET scan is nice, especially at the beginning, because it tells me how active this tumor is. There's a signal that tumors give off when their patients are injected with a sugar molecule. Cells that are actively growing rapidly take up sugar. And so the PET scan would be nice for me to have, because what I anticipate is this mass is so large that I'm not going to expect to see huge changes in the size of it over time, but I might see changes in how hot the signal is. If the signal dims over time, that tells me that we're killing off the tumor cells. We're just not seeing the change in the size of the mass. The PET scan becomes a little bit of an issue for us in the sense that we have a PET scanner available to us at another facility, but they don't do pediatric anesthesia. And even though it's a 30-minute scan, I think he's not going to be able to lay still for 30 minutes. So what I'm looking into, I have some calls out to other people to see if there's any way I can get this done. Even if I can't get this done right at this moment in time, I will try to get it done. If it's an outpatient, we do, for our patients that require sedation, they go to UCLA, but I think it's an important enough scan that we should get it done. If it happens after he gets discharged, so be it, but I'd like to have at least one. Okay, so there's a lot of movement behind the scenes, and we're just trying to all put everything together to get Marco the very best care that we can. Any questions on the phone?
I've heard a lot of words, and I've digested what I can. My wife has cancer also, so a lot of this stuff is familiar.
Yeah.
But we're just gonna put all that aside and continue on. I don't have any specific questions right now.
Okay. Well, if
other than make sure we get on that email list so we can see that stuff.
The notes, yes.
We'll get it to you.
I might have you just sign like a little email.
We'll get it to you. So this is the roadmap. This is kind of the outline of the chemo drugs that we're going to be giving and when. It's roughly given on an every 21-day cycle. I've crossed off the dosing. The cyclophosphamide dosing on this particular protocol is a little bit lower than what I would like. I want to give it a higher boost to really go after this tumor. So I've adjusted it a little bit, but it's still well within a safe zone. It's just I'm feeling that it's going to give him some better outcome than the lower dose. So that's kind of a guideline for you to use, and that's the guideline that we use for giving him his chemotherapy.
The other question I have is, could we have like more information about what
Rhabdomyosarcoma?
Yeah. I kind of like the paper one because I like to reread just so I have it in my head because I know what's going.
We can. We can definitely give you information. And then thank you for mentioning that because that brings me to the other point. A lot of times families will run out and Google things and look things up on the internet. And there's a lot of really bad information on the internet. And so we will guide you to the good sources, to the reputable sources that will give you good information. One really good source is cancer.gov, and you can type in rhabdomyosarcoma and they'll talk about pediatric rhabdomyosarcomas. Though that's where I would focus on and that's where I would look at. But don't go Googling this. Please tell your friends and other extended family members, don't go Googling this, because I've had parents come to me in tears, you know, so-and-so read this and it's completely false and it's completely not true. And then I have also had parents ask about alternative therapies. I'm going to be the first to tell you I don't know a whole lot about alternative therapies because I didn't train in them. However, I'm not averse to using them. I think that there could be a role. We have a nurse practitioner who is educated in alternative therapy. So if there's something that you want to use or that some family member says, hey, why don't we ask if we can use this, I just ask that you bring it to me first and then we'll look at it to see if it's contraindicated. There are some things that shouldn't be used with the chemotherapy we're using.
Okay. The other question is, how do you spell that?
What?
Rhabdo.
Yeah,
Sorry.
we pretty much have Rhabdo down in the
That's,
rest, you know.
you know what? That's what we call it too. In our lingo, it's rhabdo.
I'm
as
gonna
well.
go to some of, there's CureSearch and then there's APON too. And so I'll see if I can find some, a good overview.
Yeah, it is too long.
It is long. Just call it rhabdo. That's what I do.
Just wait till we get to the
Okay. Well, then if there's nothing else, Vesicostomy today. He gets to relax today, and then we'll start up the chemo tomorrow. It's okay for the nutrition through the IV to go with the chemotherapy, so.
When will that start? Tomorrow too?
Tonight.
Tonight?
When he
Okay.
comes back. We'll hook him up tonight.
So no food.
He
For
can,
chemo.
he can eat. My guess is he's not going to want to eat. Everything in his belly is so squished by this tumor, and it's probably going to become more painful to him than to eat than not.
Could that be why he was nauseous? Okay.
So I wouldn't force it,
So
and he's going to get
when we
good
start
care.
seeing, I mean, it may be wishful thinking, but when we start seeing immediate signs after the first stage of the chemo, or it's going to be a while?
It depends. Every child is so different, but most of the patients we start therapy on, probably within a week of the first drugs, you'll start seeing some changes. Maybe he's going to be a little bit more active, a little bit more
Okay.
lively. You're going to start seeing some subtle changes, but you are going to see changes.
Good.
Okay.
Okay. And so this notion, kids are amazing. This notion of, you know, what you see with adults when they get chemotherapy, they're laid out completely flat on their back. They can't do anything. They don't want to do anything. It's not like that in our kids. It's when they're feeling better, and you will be the first ones to see it.
Okay, very good.
All right. Thank you.
Thank you very much.
All right, Grandpa. Talk to you later.
Anybody
Yeah,
else
call
have
me
another
later,
comment?
okay?
Yep.
Bye,
All right,
Grandpa.
bye.
Bye-bye.
Bye-bye.
Pam, do you have an email consent form? Do you have one handy?
I do not.
Okay.
I want you to know.
Weren't they gonna talk to us too?
Huh?
Weren't they gonna talk to us too?
And what I'll probably do is just email to
Social?
you, and then you can forward it out. Okay?
Did you guys have anything for us?
Do you wanna write yours
I don't
down?
believe so,
And I'm
not right
gonna
now.
come back.
All
I
right.
think you guys got enough going on, don't you?
Yeah, you know, it's
Yeah,
definitely a
A
lot.
lot of information and stuff, yeah. So you're gonna be here for a while, so we'll kind of sort out things and get things figured out,
All right.
okay? Yeah,
you.
yep. Let's just get him through his surgery that he's in right now.
Okay,
Yep.
very good.